Welcome to the Health System CIO show. I'm your host, founder and editor-in-chief Anthony Guerra. On today's episode, I'll be speaking with Rachini Moosavi, Chief Analytics Officer with UNC Health. Rachini, thanks for joining me today.
It's a pleasure. Thank you so much for having me.
Oh, you got it. Let's start off by talking a little bit about your organization and your role.
Yeah, so I work for UNC Health, which is about a 20 hospital system spread across the state of North Carolina. We were really founded to support the mission of taking care of the health and well-being of all North Carolinians. So that's why we have hospitals that are in rural areas. We have them in our cities and other spaces. With our health system, it's not just hospitals. We also have a bunch of clinics that are part of that and employed physicians and a pretty vast network of partners. And we really are focused on trying to ensure that we can bring a lot of these great capabilities to anyone, anywhere within the state of North Carolina. And that includes some of the technology that we use. So in my role as a chief analytics officer, I help to ensure that we've got the data that comes out of our source systems that we use to support our health system and make that usable and turn it into insights that are in data and visualization type reports and dashboards, and go all the way through to some of the data science products that we create. I also help to support our AI strategy for the system, and
Mhm.
some of my team also works on interoperability for the organization.
Yeah, it's really interesting how health systems are splitting up these roles and the different titles that you see. So you are analytics. We see a lot of data and analytics
Mhm.
combined. We see now a lot of data and AI combined. But I guess it's an alphabet soup out there, and I guess hospitals grown organically over time, hundreds of years old, and it's almost you can see the organic nature of this developing and it depends on the talent suite you have in the C-suite. What is somebody doing? What's their current title? Something new comes along. Do we add it to their title? Do we add it to this other person's title? I think the idea is, well, that I've been thinking is you need a certain amount of expertise in that C-suite. You need focus on all of these things, but how you split it up really depends on your personnel. What are your thoughts?
I think you're right. I think how you split it up depends on the people and the talent you've got in your pool. But I think also, so for myself, for example, I have data analytics and AI. I don't
Hmm.
just have analytics, even though that's part of my title. But I
Okay.
think you said it extremely well, right? It becomes this alphabet soup. Are you a CDAO, a
Right.
CDAIO? Are you a CDA and AIO? Like it starts to get almost ridiculous after a little bit,
Yeah.
when you start to throw all those letters
Yep.
out there. So I think, whenever you look at any organization, and to be honest with you, there's not even a C title for a lot of the folks that are doing the job that I'm doing at many orgs. They're still using VPs and sometimes executive directors and directors to do the work, depending on their size and scale. Whenever I look for my partners, I just look for who is the head of data analytics and AI at an org. And to your point, that could live in a multitude of different places throughout an organization. So it is something that can be confusing. I don't think there's a one size fits all across an organization. But it is one that allows us, when those positions exist, regardless of what letters go into it. It's an
Yeah.
important position for any healthcare org today.
Is there anything to the idea of a organization showing its dedication to an area, its focus on an area by the level of title? I think of cybersecurity, and I think of
Mhm.
how it would be absurd this day and age not to have a CISO, to just have a director, unless you were a rural 25 bed, rural critical access hospital. Um, what do you think of that kind of stuff when it comes to all this AI data analytics? Do you think it matters?
I am going to say that I think a title really does help to ensure that you've got that focus, that you are putting that importance on it. but I don't want to judge, right? At the end of the day, I think it really comes down to the culture of an organization.
Hmm.
And if an organization still shows that dedication to ensuring things like information security are backed with the right people, with the right kind of talent, regardless of what level
Yeah.
of talent it is, regardless of what the title is, regardless of if somebody is sharing that as part of a broader title, right? I've actually seen CIOs and CISOs combined, or CTOs and CISOs combined, right?
Hmm.
Like I don't think it reflects on their how important it is to them. I think it's just finding, like you said, the talent that you've got, who is the best person to be leading those capabilities for your org, and how does that best fit within their culture.
No, and you're right. Probably a better indicator than title is access to decision-making influence. That whole seat at the
Right.
table thing, right? I don't care what you call me, but if I get in the meeting with the people that can influence things for what I'm trying to do, great. If I'm excluded from those meetings, not so great. I don't care what my title is, right? So there's some element of that.
Yeah, 100%. I think that is extremely well said. A seat at the table and a voice to be heard is the key there.
All right, very good. You have an interesting background in patient flow consulting. Am I?
Yeah.
Yeah, so patient flow consulting, revenue cycle analytics, which is really interesting. So patient flow consulting, I don't know how to think of that in terms because my brain, works in buckets. So it's like there's the business side, which is the revenue cycle, and then there's the clinical side. Patient
Hmm.
flow is interesting because it's kind of a little bit in the middle there, maybe.
It is. It is.
Revenue cycle certainly on that business side. But it's an interesting background. I don't know. How do you feel like your background helps you understand your work now, um, and maybe some areas that you had to brush up on because you hadn't been deep in that area before? Uh, so it's just very interesting how one's background can contribute to their current work. So your thoughts?
Yeah, so I will say I've had a meandering path in healthcare, just like a lot of people in finding their career. I actually started off as a nurse aide. I got
Oh,
certified in high school and worked as a nurse aide while I was in college part-time. So I had the clinical experience, and then when I graduated, I knew I wanted to really lean into the business side of healthcare. So
oh,
I did my MHA, my master's of not my MHA at the time, sorry, my BSPH, my Bachelor's of Science in Public Health, which was with a health policy and management degree that allowed me to get into that patient throughput consulting. So, to your point, a lot of it is sometimes it's clinical, sometimes it's truly operational in nature and administrative in nature. One, how fast are we turning over housekeeping beds? When does transport get there? How do you ensure that those are timely? I spent a lot of time in bed management working with our clinical folks that were making decisions for on-service and off-service placements, and how we're thinking about the transfers that are coming in, right? So all of those pieces, the data, the information, the technology that's leveraged within it really has helped to inform a lot of the things that I do today in my role. My time in Rev Cycle, gosh, I spent 9 years there. Also had an analytics component to it. So it was part operational in terms of needing to sometimes write off some of the claims that we had sitting out there that were within the threshold as a director that I was supposed to be reviewing and writing off, but also analytics in nature to really support our professional billing side of UNC Health for those 9 years of time that I was there. So that was a fun kind of dyad, kind of operational plus analytics kind of experience that also really helped contribute to my understanding of how these operational reporting teams need to manage the data and information that they're using to be successful.
mm-hmm.
And then once I left all of that and started data governance at UNC Health, that was another big whirlwind of something new I had to learn. I was outside of the scope of health care operations and management and fully into the data and analytics side of the organization. And so I spent a lot of time going to conferences and asking people questions about what is data governance? How are you doing it? What is this concept of top down versus bottom up versus, just all the different models that people are using. And then when I had the privilege to step into my current role, to take over data and analytics for the health system in the hub part of our hub and spoke model for data and analytics. I leveraged all of this experience throughout my entire career, all the different nuances and the pieces that I've learned over time. And I leverage that often when working with a lot of our stakeholders throughout our organization to ensure that we're trying to get the best kind of support to them that they might need.
Very good. Very good. Lots of directions to go here. Some high level stuff, some detailed stuff. When you're talking about data governance, my thought was that data governance, if you think of data as a cycle, it gets created and then it gets normalized and then it gets used by people who are trying to do their jobs better. I think of data governance more towards the front end. So it's like you were dealing with analytics and that might be towards the back end. Now you're studying data governance, which is the front end. So let's get this better from the inception, from when the data starts. And it's a process of flowing through. And then I thought about the idea of, what's the ultimate end game here? The ultimate end game of analytics and data is to be useful to those trying to do certain work, right? We think of the clinicians. Ultimately, we want to be useful to people. And I guess there's lots of ways to get that wrong. You could produce useful data that isn't appeared to the right person at the right time. You can surface data to the right person at the right time that's wrong, or it's right, but it's not what they need at that time. So there's lots of ways, and so much of this probably has to do with in everybody I speak to, in every element of the IT work and health system, so much of this has to do with spending time with those you're trying to serve to deeply understand what they actually need, when they need it, and what they want, and how you're doing with trying to satisfy that need. Those interactions, rather than just sort of, that concept of staying in the office and not going to Gemba and all that stuff. So anywhere you want to go there.
I love so much of how you frame that, Anthony. Let's lean in first on the data governance comments that you made. When I was in Rev Cycle, I think the thing that hit me the most when I accepted the data governance executive director role for UNC Health to create data governance for the first time was the realization that I had been doing data governance for Rev Cycle for 9 years and didn't even know it. Right. And I think it's because of everything that you just said. It is a recognition that data is truly owned by the people that are creating that data, that are managing that data, that speak to the workflows and the outcomes you're trying to drive to, and to the how we plan to measure it, and what does that measurement mean to how we're going to analyze our own capabilities and where we're trying to make improvements, and so on and so forth. So when I was on the rev cycle side of things, I had made sure that data and analytics conversations took place in our change control group for all the operational processes that were going on in rev cycle. Again, I didn't know to call that data governance at the time, but I knew that any decisions we were making on the operational side would flow into the data that my team was responsible for as a steward of that data. Right? We were not necessarily the owners. The business folks are the owners of it. The folks that are creating it are the owners. But as one of the custodians and stewards of that data, it was important for me to raise my hand and say, hey, here's an opportunity where we might be fundamentally shifting a definition, or how we might look at a certain process could change how we are able to analyze this on the back end. And is that a good thing or a bad thing? Is that what we're intending to do? Let's make some conscious decisions here. So if you fast forward from that to your other comments that you were making, there's that relationship with people, being able to take a giant step back and not just say, here's my requirements that you put into a ticket that you asked me to fulfill, right? But to take a step back and say, well, what are you actually trying to solve? How can I help you? What's the problem that we're trying to address, right? And having that conversation really steers us away from building about 10 bad products before we actually get to the root of it, right? And oftentimes that is a simple 5-minute conversation. And I've said this to my team over and over again, analytics is not a ticket taking kind of operation. And the day that we treat it as such means that we are wasting our time. We have to make sure that we are having those conversations, ensuring that the solution is actually a fit for the need and the problem that we're trying to solve for, And sometimes we can use reusable assets for it. So to your point, can we create some trusted kind of assets for common questions that are being asked so people know where to get to it fast, right?
Hmm.
And other times it is when we're building something custom, we have to still take a bigger step back and say, is there a better path here? I also think that the future of where we're heading with data and analytics is curating a really great semantic layer that has an incredible ontology that backs it up so that people can ask natural language questions of their data and get to those responses in a more timely fashion that can have that iterative kind of back and forth with their data immediately and get to the response that they need in a trusted way, as opposed to relying on a ticketing system, which again is still broken and takes too long.
I mean, that's so right. I mean, it just on an instinctive level. I mean, the experience you get as a regular consumer interacting with the big LLMs is amazing. The back and forth is amazing. That has become the experience that everybody wants,
Mhm.
right? They want to just natural language ask a question about a patient into the system and just get an answer. That's what they want. They don't, like you said, they don't want to put in a ticket. They don't want to create a report. They don't want to click in 50 places. We've moved from Googling something where you get a whole bunch of links and you have to still figure out the answer, right? This is still work. You've helped me, but it's work. To here's the answer. I've done I hit 15, 20 sites, done the research, and it's not perfect. We know that. And that's a challenge there too. But that is the experience. So you talked a little bit about how you think technically you get there with that ontology layer and semantic layer. So is that a generally agreed upon vision, or are there different visions of how to achieve that?
I ask those questions of peers all the time. And in fact, I've been working with one of our vendors to say, you know what, I've attended a couple of events where we've had great partners throughout healthcare that have said, here is my MVP. I just created it yesterday. So don't expect great things out of it, but we're using this to learn and we want to share back what we're learning. So one of the things I've said to one of the vendor partners is, do a datathon or a hackathon for us. Allow us to come to the table together, solve a real world healthcare problem. We can bring our own data to the table. We don't need any de-identified data set or something. Just teach us how to do this using common tools and tech, and then allow us to just play in that safe playground where we can see, is it the ontology that makes a difference? Is it that semantic layer that makes a difference? Is it the knowledge graph that's going to make the difference, right? Like which one of these things or all of them combined are really going to be the differentiator that gets us not just to timely and available and convenient, but safe, reliable, and trustworthy.
Yeah, that's really interesting. This safe playground concept is in another area of healthcare. An organization, I think I've got the interview set up. They're going to do they're going to do simulations. So they've got some sort of simulations they're doing to understand the potential impact of different tools they might introduce on clinician workflow. So instead of sort of actually rolling it out, they're doing some sort of simulations that'll help them figure it out. You talk about a safe playground. It's really, and I think this all relates to AI in the sense of the speed of change, right? So change is happening so fast, we don't know exactly the best way to do certain things. We don't know because the tools are changing so fast. So how do we deal with that? How do we operate in a flexible, fail fast, keep trying things, maybe bleeding edge, maybe leading edge. I don't know. Bleeding edge is scary, you know. So is that what you're trying to do? You're trying to say from the things I'm responsible for, how do we stay right up at that edge? Because what's wild is
Mhm.
you'll see I try and monitor everything going on as much as I can, and everybody's doing something interesting. Everybody's doing something like groundbreaking. They're over here and over there, and they're all doing something a little
Mhm.
different in a different area. But it's almost like a little meerkat picks its head up, and you're just going like this because there's so much going on. So how do you deal with that on your end?
I don't think that any of us deal with it perfectly. But we are doing our best to keep up the whirlwind that is the pace of change that's happening right now. The reality is that the technology companies that are rolling things out, even within their own organizations, they can't keep up with the pace of change. Right. So I think the sooner we embrace that we are in a perpetual state of ambiguity, that there are a ton of opportunities in front of us and available to us. And it is our job to help our teammates to really upskill, reskill, and challenge the way we've always worked, to think differently, act differently, to create some safe spaces where it's possible. And in healthcare, that can feel like it's few and far between, but it's more than we often think. We really think of healthcare as almost a giant, this like big city, right? That
Hmm.
we're trying to support with all these different operations capabilities, administrative capabilities, healthcare capabilities. The level of risk is different in a lot of different pockets. So if we can find the right places and the right opportunities to continuously assess, evaluate, pilot, fail fast, build things and try it out and change direction. I think that's the best that we can do today, because the reality is, let me give you an example. I've talked to no fewer than 3 organizations, maybe 4 organizations, that have said that they have some version of a BI modernization program going on, or an analytics modernization
Hmm.
program going on. And what that means to each of these organizations is fairly similar when you look under the hood. A lot of us are doing the same things, but the reality is the technology capabilities are moving so fast that our like analytics modernization efforts are almost, they're this close to being at risk of not being modern at all by the time we get it in there, because as soon as you set the plan, the goalpost moves, right? And we just have to keep looking at it and evaluating and creating a solid foundation that we can build from, that allows us to continue to iterate and move with where the capabilities are heading to next.
Right. It's fascinating times.
It is.
We talked a little bit about that bleeding edge, cutting edge thing, and all the people doing new things. There's a completely opposite end of the spectrum on this, and that's sort of the meat and potatoes kind of basic stuff that's still a big problem. Like, and I think of medication reconciliation lists, and like they're a mess, right? I mean, I've read some good stuff. Dr. John Lee writes about this. Really amazing things he's writing, give you incredible insights into, sometimes, and we bifurcate. We think of this high level AI kind of cutting edge stuff, and then there's this sort of meat and potatoes like mess on the ground in healthcare. And I guess we have to do both, but we certainly can't forget that stuff on the ground, because that's when we lose touch with the clinicians in the trenches doing the hard work, dealing with some of the stuff that's frustrating them. And if they hear about all this high level stuff, they probably get really frustrated. Like, you have to take care of this stuff first still. And that stuff is really hard, or it would have been fixed already. So I wonder if you have any thoughts around that.
Yeah, I think you're absolutely right. What we often talk about is that there is the things that we're trying to transform, and then there's a lot of keep the lights on work that are still going on, right? We've got to continuously reinvest in infrastructure and maintaining the status quo of the capabilities that are out there, at the same time that we are transforming and pushing for something bigger and greater and different. And as we all know, change and different can be costly.
Hmm.
So, to your point, the things that we are aligning to, that we're trying to really invest in that fail fast space and that innovative space, are things that are aligned back to our own priorities as a health system, back to our strategic needs, things that we have said as an organization, this is what we need to move the needle on. And so instead of chasing the shiny, we're trying to chase things that are practical, that really do solve problems that are been articulated in a way that we know that by addressing XYZ needs, we are then able to really, really, truly try and address some core issues that we're trying to solve or opportunities that we're trying to address. And I think that allows folks to feel like the investments are worth it because it's specific to the things that we've said are important to us as an organization. So med reconciliation, for example, right? That's something we've known is the root of a lot of problems that we think about in the clinical space. It's time consuming. Different folks within the organization are doing it constantly at different points, iterations during a visit. It's hard for patients as well. They have to know all their medications by name and how often they're taking it and what that looks like. There's often even sometimes pharmaceutical groups that are involved, and what does that look like? So lots of different data points and information. I've seen some great products, some different things that are coming out from the AI space of can we turn some of this over to the people who know the most about what medications that are being taken and administered and adhered to, which is the patient, and how do we empower a patient to be able to provide us the information on the medications that they're taking and reconciling in an easily consumable way? Can it be
Hmm.
conversational in nature? Does it really need to be text-based or printed in some form or fashion, right? Like
Hmm.
all of these different things is where people are saying, here's a problem in healthcare. How do we make it easier for everybody involved? And then what are the downstream impacts once we make that easier? So I do think it's an interesting time and space to be in health tech because you're starting to be able to see the light at the end of the tunnel for some problems we've had in healthcare for a very long time. We'll just have to see which ones pan out at the end of the day.
That's right. That's right. Very well said. Let's just a little bit more go into the idea of making sure we're doing, and I know this is governance, making sure, not data governance, this is sort of just general governance or however you want to put it, making sure we're working on the right things. And I guess to a large degree, that's got to be decided by the users or operations, right? We want to, as IT, or if you consider yourself IT, we want to be working on the thing. There's strategic objectives that are put down from the C-suite level, like here are the organization's strategic objectives, and then there are operations, which is saying, this is what we think is important, and theoretically, IT is there to support both those things, the general
Mm-hmm.
objectives and then the specific things the operations want, if those things fall under the strategic objectives, right? Okay, now we're going to support you with IT. We want to do two things here. And again, some of this is my theorization after talking about this for a long time. We want to do two things as IT. We want to support you in what you've requested, but we also want to lead in a sense. We want to show you what is possible. So we do need to deeply understand your challenges so that we could say, hey, did you know there's this? Or did you know IT could do this? There's systems that can do this. If we're just
Mm-hmm.
order takers, we're never doing that. So we don't want to do that. We want to do both. Um, what is the best way for you think to make sure that you are doing things for operations and not to operations, which has been the classic problem of old IT.
Yeah.
And I'm picturing an exchange where the users are asking for things and IT is not hearing that or ignoring that and saying, oh, look what we found for you. So there's that just, like a classic husband and wife not hearing each other thing. And but your thoughts around how you could sort of just make sure you're being responsive to what the users want.
Yeah. I think I'm going to go a very simple route in answering your question and say I think we need to give our technical folks the same degree of communications and relationship and change management training as we do all the business folks.
Hmm.
Part of the biggest challenge in ensuring that you're not building two different tracks that will never meet in the middle is ensuring that people are seeking to understand that we're hearing each other, but it's a balancing act, right? When it comes down to our technical teams, many of them are not trying to be put their blinders on and say, this is all I can give you. Oftentimes, what they're trying to say is, we've already invested in a technology. Here's what's available to us today, right? And we're underutilizing it. But in order to utilize it more, we're going to need you as our business partners to change your workflows, to standardize and systematize how you do things. Those are hard conversations, right? Those are things that the average person in an IT role was never trained to handle those kind of conversations, right? So if it, and at the same time, they can't come in and say, "I've already given it to you, just use it." That's not the right answer, right? Like it has to be a balance in the understanding of what is the problem we're trying to solve, what is the technology that's already out there? Is there a workflow gap, a technology gap, a capability gap? Like where is the gap that's keeping us from being at this ideal space that we need to get to? And then let's solve for the right problem. And the reason that I'm framing it that way is oftentimes people look at a space and they say, we just need to throw technology at it. But I'm telling you, every time we have technology in search of a problem, everyone loses. Everyone loses. We spend more money and we never fix the problem. We never get to the solution that we're trying to get to. And we end up starting over and likely doing it again one to
Hmm.
two more times, at least until people start to actually recognize that it's a combination of people, process, and technology together to get to that solution. And that we sometimes have to go into the spaces that people don't want to talk about in order to get to the end result that we want to get to.
Yeah, well, a couple things there. Great stuff. Every time you use the word conversations, I picture my teenager who, they can't talk. They don't know how to talk. They don't know how to conversation. And I'm guessing that that's not exclusive to him, that we, because of technology and the way kids grew up, to a certain degree, we've lost the ability to talk face to face in real time, and everything's got to be asynchronous because it's less scary. And but to your point, you mentioned the idea of a 5 minute conversation. It's 100% right. I'm sure we've all been involved in email chains where you're just not understanding each other, or it's a little complex and it's exhausting. And you're like, if we got on the phone for 5 minutes, we would clear this up. And if you wind up doing that, you do clear it up. So, is that part of the problem here? Are we losing, and as the younger people, are we losing that ability, or is it still there and they just need a little training?
I think it's all of the above is
Yeah,
what I would say, right? And it's not just the younger people. To your point, post COVID in
yep,
this very just asynchronous kind of world, it's how a lot of us have learned to function.
yep,
I mean, how many people coming back from the pandemic still have a hard time holding eye contact with
yep,
people because
yep,
they're not used to it
yep,
anymore, right? And calling someone on the phone, that's almost unheard of, right?
absolutely.
Now we have turned on the positive side using tools like instant chat of whatever tool you use in technology. My organization uses Teams. When I ping someone on Teams, if it feels like it's the longest conversation I'm ever going to have, I just quickly say, "Can I just call you really quick?" Right? And hit the quick button at the top because it saves us a bunch of time, right? But it's not where people are used to it anymore. We don't just pick up the phone as the first level of response. So the phone is the last level of response typically when we've exhausted the chat messages and the emails and the everything else. And you are right, it has switched things up. But one of the things I'm really proud of with UNC Health in our information services group is we've really been investing in communication training and what it means to be a good partner for our business folks. In fact, we've been developing training over the last couple of years and partnering with communication experts within our health system to say, how can we recognize that a big part of our ability to be successful as an organization is to hear each other and to respond to each other in a way that it gets us to the best outcome. So we are investing in it. We're co-developing training specific to like technical staff to help them build those skills. And I'm hopeful that the same is true for my teenagers too, because at the end of the day, This is how the world will continue to evolve, even in an AI world, especially as more things get on automated. Communication and relationships will be the backbone of what humans really bring to the table in a lot of these situations.
Oh, I think that's brilliant. And yeah, I'm like, how is this kid going to do an interview? He's 16. Like, how is he going to go? And like, you have to keep your head up. Like, you can't. It's just a little scary. And then there's my sister at the other end of the spectrum. You text my sister something that's needs a one word response. She's going to call you, and you'll be on
Oh
the phone for
gosh.
2 hours.
Oh
She's great.
goodness.
She's great. All right, we're almost out of time. Just you mentioned really interesting. You mentioned workflows. You mentioned possibly suggesting this is like the third rail or whatever the term is like dynamite in healthcare is changing workflows, changing clinical workflows. Like everyone talks about that as if it's absolutely sacred. You cannot touch it. If you're doing anything to disturb it, disrupt it, you will be fired immediately. Go away. Right? That's sort of the. But you mentioned like, and then I've heard once in a while people talk about the idea of redesigning workflows around technology. Um, so that's you hear that more rarely. Usually you hear it spoken of as something very sacred. I don't think you see it that way, but I'd like your thoughts on that concept.
Yeah. Well, first of all, we created a group called our Intelligent Optimization and Automation Work Group just to focus on how can we co-create with our business and clinical partners technology-enabled workflows. So it's a recognition that the technology has evolved and there's things that we still have continued to throw people at, again augmenting and adding more people time and steps to, as opposed to thinking about the most efficient path to get there. And if we would just pause and take the time to redesign it, take out some of the automation steps and give that to the tech to handle, while we leave the most critical aspects of it for the people to handle, that we can have force multipliers to get to where we go to. Now, those are sometimes, I'm not going to say easy because it's never easy, right? Whenever you are moving someone's cheese,
Mm,
it can be very personal. It's going to feel like a pain point to someone, right? But it's necessary and it helps us to evolve and stay relevant within the business that we're trying to deliver. What I find on the clinical and operational side is when you do have the kind of partnership with your clinical and operational folks where they are coming to you and saying, hey, I just saw this great product and I want this tech. Oftentimes we can look at it together and say, this tech is not so foreign to what we've got today, but it requires you to standardize. You want that impact, we've got to talk about the how we get things done. And
mhm.
in fact, if you even purchase that technology, we still have to standardize or change our workflow to fit that tech, right? And it can open the door for a different conversation sometimes. And the other reason that I say relationships are so important, and it's never a one size fits all, because you never know if you get to start from zero with someone or if you're working through some latent pain that they've experienced with something in the past, right? So you often just have to stay in this relationship with people, understanding what's motivating them, what's keeping them from where they need to get to, and what is the right answer for the problem that you're trying to solve. Sometimes it is the technology. Oftentimes it's not the tech, and it is the workflow, the people, the process that we've brought to the table and how we need to re-engineer it for that capability. So I do think it's a willingness to ask the question, right? So that we don't stay in that spiral of technology or in search of a problem.
That's really good stuff. You mentioned the idea of someone um, maybe having some baggage, if we can use that word, of maybe they had a bad experience with IT or someone, and you don't even know about it. It was your predecessor or whatever, and that that may be framing their um, attitude to the conversation, and it'd be good to know that, and maybe that's where some of this training to try and engage and be like trying to understand. Maybe if you're getting sort of non-cooperation or someone just seems disturbed by, like what's going on, like what, and sometimes someone's just having a bad day, right? So
Mhm.
that's where you get some of this, and especially clinicians can have a really bad day, and if you catch them on the wrong day, maybe just today's not the day. Maybe we talk tomorrow. Maybe we just reschedule. This is all sort of that soft skill stuff that you're trying to train your people on. So it's just fascinating that you guys are focused on that. Anything more you want to add on that?
No, I whenever I meet with students, the same way when, I talk to teammates in any job at UNC Health, I really do try and remind them that the biggest part of our jobs in just about every single role is the people, right? We're in healthcare, you're there to serve people, whether it's your patients or it's your own teammates or is some kind of process that involves a person. Recognizing the human aspect of it, just like you were saying, is such a big part of our success and failure, right? And I like to tell my staff and my teammates that we are all humans. When we come to the table, you bring your whole self and you're going to have your good days and bad days. And that's why we're all partners in this. If you need to rely on a teammate, you rely on a teammate to get something done. Right. But we all do the best we can with what we've got at any given point in time, but really leaning into how to communicate with one another and finding the right balance for your relationships with people can help you tenfold to achieve what you're trying to get to. So much in your career as well as in the outcomes that you're trying to drive for your organization.
It's brilliant. Yeah, I had an interview yesterday, and they just continued to talk about that human aspect of being effective in these roles. And it's interesting that, yeah, the patient, if you think of the patient at the end of the chain, you may be a few links removed from the patient. So you may have the nurse, the doctor, but you're supporting them. So, but at
Mhm.
the end of the chain is the patient. And if you remember that human to human, and we're trying to put the humanity back in healthcare, right? We're trying to allow the clinicians to be present as human beings with the patient. So we're trying to help take some of the things off their plate that have been on their plate around documentation. So just restoring the humanity to healthcare, keeping the patient in focus. So great stuff, Rachini. I want to thank you so much for your time today. This was really a pleasure. I hope we can catch up with you again down the road.
Sounds great. Thank you so much, Anthony, for having me.
Have a great day.
You too.